Welcome to MediCRUSH, where I help you crush your medical examinations. In this video, we will be covering Gastroesophageal Reflux Disease, or GERD for short. Now, before we explain about the disease, we have to understand the anatomy and the function of the lower esophageal sphincter. Now, the lower esophageal sphincter normally protects the lower esophageal mucosa from harsh damage from the acid exposure. And that's because normally when you swallow, the lower esophageal sphincter relaxes to allow for food to pass into the stomach. In between meals, however, the sphincter contracts with increased LES tone to prevent reflux of acidic contents into the esophagus. So in GERD, what happens is you get this reflux of acidic contents from the stomach into the esophagus due to either decreased LES tone, meaning decreased muscle tone, or transient increased LES relaxation. We'll call that LES incompetency. And that allows for the acidic contents to go back into the esophagus. So what are some risk factors for GERD? Anything that will decrease the tone of the lower esophageal sphincter. Some very important ones that are tested about is obesity, pregnancy, alcohol intake, using nicotine or tobacco, coffee consumption, and older age, especially over the age of 50. An important medical condition associated with GERD is a hiatal hernia. The hiatus is an opening in the diaphragm that allows for the esophagus to reach the stomach. Now, in addition to the increased pressure of the lower esophagus via the sphincter, the diaphragm also plays a role in increasing the LES pressure. So what happens is the diaphragm will contract, and that will also help to increase the LES pressure. In the hiatal hernia, the upper part of the stomach bypasses the diaphragm, and therefore you lose that additional control of the pressure in the lower esophagus, and that can result in causing GERD symptoms, and that's an anatomic disruption of the gastroesophageal junction. Some other conditions include diabetes mellitus, because diabetes can cause gastroparesis or delayed emptying of the stomach, which can increase the risk for GERD. Scleroderma and Zollinger-Ellison syndrome is another medical condition associated with increased risk for GERD. In Zollinger-Ellison syndrome, you have a gastronome which produces a bunch of gastrin that causes increased hydrochloric acid production, which can increase the damage to the esophagus. Some important medications that can increase the risk for GERD that may affect this pressure of the lower esophagus include calcium channel blockers, beta-2 agonists such as albuterol, anticholinergic medications such as tricyclic antidepressants and antihistamines, benzodiazepines, narcotics, progesterone, and statins. Now, when we think of the symptoms of GERD, I like to break it down into three types. There's what I call classic GERD, there's what I call atypical GERD, and there's complicated GERD. In terms of typical GERD, those are two symptoms. It's going to be heartburn, also known as pyrosis. Think of a pyromaniac for fire. So heartburn, which is hallmark. The patient may feel a burning sensation in the retrosternal area, especially when in the supine or reclined position. The other classic symptom of GERD is regurgitation. So pretty much simply put, if the acid comes back up, I'll feel it as a burning sensation, or I'll feel this acidic contents in the mouth when the acid comes up. If they have these classic symptoms of GERD, either heartburn and or regurgitation, it is a clinical diagnosis, and the only thing you have to worry about is that you always want to rule out a cardiac etiology for this GERD, because the most common cause of chest pain that's non-cardiac related is GERD. On physical examination, there may be nothing. Oftentimes, it's a completely normal or benign examination. If they have severe GERD that's frequent, they may get dental enamel erosion from the acid destroying the enamel, or even wheezing. The second type of symptoms of GERD are what are known as the atypical symptoms of GERD. As I said before, GERD can mimic chest pain, and that's because during development, a lot of the nerves for the stomach and the heart are shared. And so therefore, they present with a substernal squeezing, burning chest pain that can radiate to the jaw and the arms that can mimic stable angina. Again, GERD is the most common non-cardiac cause of chest pain if you do a full workup and is not cardiac related. Other atypical symptoms of GERD include if the acid comes up and then goes into the lungs, that can result in chronic cough and wheezing from aspiration of the acidic gastric contents. The acid causes the airways to narrow because it's an irritant. As it comes up into the throat, it can cause laryngitis, which can manifest as hoarseness. Now, the third type of GERD symptoms are what we call the alarm symptoms. If they present with any of these alarm symptoms, you have to be very worried they may have a complication of GERD. So these alarm symptoms include dysphagia, difficulty swallowing, odynophagia, painful swallowing, unexplained weight loss, GI bleeding, that can include melanoma, dark-colored stools, or hematemesis, iron deficiency anemia, or a patient over the age of 60 with long-standing GERD. If they have any of these alarm symptoms, it's very important to recognize that on examinations because any of these alarm symptoms require an upper endoscopy to rule out complications of GERD. Remember that classic GERD is a clinical diagnosis. Complicated GERD requires an upper endoscopy with biopsy to rule out complications of GERD. So what are the most common complications? There are 4 major complications, and they all have to go back to the pathophysiology. Remember, in GERD, the acid is coming up. If the acid comes up and it causes inflammation of the esophagus, we call that erosive esophagitis. They get either erosions or ulcers from this exposure to this acidic content. GERD is the most common cause of esophagitis. If the acid comes up and it causes damage and it starts to heal by scarring, eventually the scar tissue can lead to narrowing of the esophagus, and we call that an esophageal stricture. So again, they can present with weight loss, odynophagia, and dysphagia. The third complication of GERD is Barrett's esophagus. Now, normally the cells that line the esophagus are your stratified squamous epithelial cells. But if you get this constant exposure to acid and acid, then your body says, you know what? Let's take some of the columnar epithelial cells of the stomach and migrate them into the lower esophagus because they're better able to handle this high acidic environment. But these cells don't normally belong there, so we call that metaplasia. So if you see this classic columnar metaplasia in the lower esophagus, that is Barrett's esophagus. Now, usually it doesn't cause symptoms, but its importance lies in the fact that it is a precursor for developing the last complication, which is esophageal adenocarcinoma. So it can result in esophageal cancer, specifically esophageal adenocarcinoma. So again, the 4 complications are all due to acid in the lower esophagus. It can be inflammation esophagitis, it could be an esophageal stricture, it could be Barrett's, or malignancy, esophageal adenocarcinoma. Notice for those 4 complications, I have to see it. Do I see inflammation esophagitis? Do I see a stricture narrowing? Do I see those metaplastic changes? Or do I see a malignancy? So that's why the upper endoscopy is the most important test if you suspect a complicated GERD picture. Now, if it's classic GERD, it is a clinical diagnosis. If they have classic symptoms, again, heartburn and or regurg without the alarm symptoms, very important. Classic symptoms without alarm symptoms, you can make a clinical diagnosis of GERD. But again, we always try to rule out cardiac causes, especially if they have cardiac risk factors or if they're having active chest pain, because again, GERD is the most common non-cardiac cause of chest pain. And that may include getting an EKG and or enzymes depending on the clinical situation. In patients with any of the alarm symptoms, odynophagia, dysphagia, weight loss, bleeding, you always want to do an upper endoscopy with biopsy to rule out those complications of GERD. Remember that EGD is not helpful to make the diagnosis of classic GERD because if it's classic GERD without complications, you won't see anything on upper endoscopy. Its use is really for anyone with risk factors for complications of GERD. Let's say they have odynophagia, dysphagia, and you do an upper endoscopy, which is the first diagnostic test, and it's negative, then you may consider doing a high resolution manometry. In other words, I want to measure the pressure of the lower esophagus and see what happens. This could be helpful to rule out esophageal motility disorders that can mimic GERD. Also, if you decide to do surgical management of GERD, we sometimes will do manometry prior to doing surgery. The criterion standard or gold standard test to make the diagnosis of GERD is a 24-hour ambulatory pH monitoring. They put in a probe, and within 24 hours, they measure how many times the pH drops due to acid coming up. Remember that GERD is acid has to come up. I can have a lower esophageal pressure without acid coming up. And so by measuring the pH, I measure how many times the acid actually refluxes into the esophagus. We often do this test if, let's say, someone comes with classic GERD, you try to treat them for classic GERD and they still have persistent symptoms, and you're like, is this GERD or could it be something else? And you want to really make sure that it truly is GERD. That's when you will do a 24-hour pH monitoring for GERD. Or it could also be used to determine the effectiveness of your management for GERD. So simply put, if they have classic symptoms of GERD, heartburn and or regurg, without the alarm symptoms, it is a clinical diagnosis. If you want to make the definitive diagnosis, you do a 24-hour ambulatory pH monitoring. If they have any of those alarm symptoms, you want to do an upper endoscopy. If the upper endoscopy is negative with odynophagia and dysphagia or chest pain, you may consider an esophageal manometry. In terms of management of GERD, lifestyle modifications is the backbone of any therapy for GERD, and that includes avoidance of the supine position after meals, because that will allow for the reduction of acid from coming up when you're lying supine. That's avoiding meals a couple of hours before bedtime to allow it to clear the stomach and not reflux into the esophagus. Avoidance of large meals, because large meals can slow down GI motility. Again, avoidance of any food known to delay gastric emptying. That can include citrus-based products, tomato-based products, caffeinated beverages and coffee, chocolate, or some other very important ones as well. And of course, other lifestyle changes. So again, smoking cessation for smokers, weight loss if the patient's obese, decreased alcohol. And again, if they're on a medication that are known to cause it, you may want to consider either decreasing or switching to another medication. Now, if someone has none of the alarm features besides the classic lifestyle changes, you can do acid suppression therapy. Now, the two depends on which type of GERD you have. If the patient has symptoms of GERD that are 2 times a week or more, we call that persistent GERD. Or if it's severe GERD, the preferred medical management will be a proton pump inhibitor such as your azoles, omeprazole, pantoprazole, lansoprazole. If they have what we call intermittent GERD, meaning that the symptoms of GERD happen less than 2 times a week, then in addition to lifestyle changes, you can use an H2 blocker such as famotidine for patients with intermittent GERD. So if you get a classic GERD question, it's very important to pay attention to how often are they developing the symptoms of GERD. 2 times a week or greater, add a PPI. Less than 2 times a week, and if it's intermittent, you can use an H2 blocker. This is my simple chart or algorithm. If they come with alarm symptoms, odynophagia, dysphagia, weight loss, you should do an upper endoscopy with biopsy to rule out complications of GERD. If they have classic GERD and it's intermittent GERD, less than 2 times a week, we do lifestyle changes and you can add on an H2 blocker as needed. If they have persistent GERD defined as symptoms for 2 times a week or greater, we want to do lifestyle changes and we often can add on a daily proton pump inhibitor. Well, Dwayne, I tried the lifestyle changes and I tried a daily PPI and I still have symptoms that are classic, very important without the alarm symptoms, then you have a couple of options. You can switch to taking the PPI twice daily. You can switch to another PPI if that's not working and see if that helps with the symptoms. Well, then I tried switching to PPI twice daily and I still have classic symptoms without alarm symptoms. In that case, you want to make sure that it's truly GERD. You will do esophageal pH monitoring, which is the gold standard test for GERD, and you can consider maybe doing an upper endoscopy to rule out some possible complications of GERD. That's a simple way to think about how to approach the management of GERD. So let's say you tried all of those things. You tried lifestyle change, you tried medication adjustment, and they still have symptoms. Your definitive management is surgical management, and we call that the Nissen fundoplication, often done laparoscopically. So what they do is they pretty much take the fundus of the stomach and they kind of wrap it around the low esophageal sphincter and they put sutures, so they kind of help to create this increased pressure by wrapping the fundus around the esophagus. So now let's test your knowledge with a few questions. For this section, I want you to pause the question when you see it to give yourself enough time to answer it, and then I'll walk you through the answer. So in this case, what is the most likely underlying primary mechanism of this condition? The patient presents with classic symptoms of GERD and they have a high BMI. Remember that obesity is a risk factor for decreasing LES pressure, and therefore for GERD, you have a decreased lower esophageal sphincter pressure, which results in an incompetent gastroesophageal junction. When you think of GERD, think of three types of GERD. There's classic GERD, which is heartburn and or regurg. There's atypical GERD, which can include chest pain and wheezing. And there is what we call the alarm symptoms. Again, dysphagia, odonophagia, weight loss, iron deficiency anemia, GI bleeding. Older patients, you want to get an upper endoscopy with biopsy to rule out the 4 complications of GERD. So what is the best next step? In this case here, this patient has symptoms of classic GERD. Very importantly, they have no alarm symptoms. If it's classic GERD, you want to focus on the frequency and the severity of GERD. In this case, since it's more than 2 times a week, that'll be hallmark for persistent GERD. If it's persistent GERD without alarm features, you want to do lifestyle modifications and a daily proton pump inhibitor such as omeprazole for classic GERD that is persistent without alarm symptoms. So in this case, which of the following medications is most likely to increase symptoms of GERD? We know that anticholinergic medications such as tricyclic antidepressants like amitriptyline will increase the risk for GERD because they decrease the LES pressure. Calcium channel blockers, beta agonists are some other very important medications that can also increase the risk for GERD. In terms of GERD, that's where you have a decreased LES pressure that results in reflux of acidic content. You want to make sure that there's increased acidic content in the lower esophageal area, and therefore the preferred test to make the diagnosis of GERD is going to be 24-hour pH monitoring. That is the gold standard or criterion standard to make the diagnosis of GERD, especially if you have to confirm it if they have GERD that is not responsive to your trial of PPI after doing twice daily. You may want to consider to confirm for sure that GERD is present. So what is the most appropriate initial therapy for this patient? You have a patient that presents with symptoms of classic GERD, and it's once every week, and there are no alarm symptoms. So in this case, we have classic intermittent GERD. If you have classic intermittent GERD without alarm symptoms, we do lifestyle changes plus a H2 blocker as needed, such as famotidine. In this case, you have a patient that's over the age of 60 that has difficulty swallowing food and food getting stuck, which is classic for dysphagia. So they have alarm symptoms of GERD. If you have alarm symptoms, the best test to look for alarm symptoms will be an upper endoscopy with biopsy to look for evidence of these alarm symptoms. Is there a stricture? Is there esophagitis? Or is there something even worse? What is the best next step in this treatment? This patient presented with symptoms of heartburn and regurg, and they were taking a PPI daily. They still have no alarm symptoms, so the best next thing to do for this patient is to switch to a twice daily version of a PPI. This patient has a long-standing history of GERD for 20 years, and they do an upper endoscopy, and they see the classic metaplastic changes where the columnar cells now line the lower esophagus, known as Barrett's esophagus. If you have Barrett's esophagus, that is a precursor for esophageal cancer, specifically esophageal adenocarcinoma, making that the best answer here. So I hope that you found this video helpful. If you did, please like this video. Also comment, let me know which part of this video was helpful for you. And as always, share with your friends. Sharing is caring. And last but not least, subscribe to this video. You don't want to miss out when I drop a new one, so subscribe to this video and receive notifications. And as always, you crushed it.